It's another Wellness Wednesday, and I'm excited to be back in the JN Life Class series. I am your host, Kamala McWhinney, and I am ready for tonight's conversation. So I see quite a few of you running into the room with your good energy as always. Welcome to the space. And I always invite you to make yourselves comfortable. Pull up your chair, relax in your divan or your sofa, get your water, your wine, whatever you sip on, and get ready for another intimate and informative conversation in the JN Life Classes special 3-part series where we're focusing on the virus and the vaccine. This evening's conversation is going to focus specifically on chronic illnesses and, importantly, staying well, staying healthy during COVID-19. All right? So for those persons who you know, friends or family, other loved ones who you know may currently be managing, living with, recently diagnosed with a chronic illness, now is the time to link them up and say Life Class is on. We have a powerful and warm and relatable doctor with us this evening to help us to navigate this conversation. So it's not just Kamala talking things, all right? So welcome again to Life Class. I would love to invite to come on stage with me today, Dr. Patrice Francis-Emmanuel. Dr. Emmanuel, welcome to Life Class.
Good afternoon and good evening, rather.
Good
Hi,
evening.
Kamala, and hi
Happy
to all our listeners. Thank you so much, and the same to you and all the viewers.
Thank you so much. How are you doing today,
Good to be here. I am good. I am wonderful. End of a long day. I think everybody's, a little bit low in energy at this point, but of course, being a part of this forum is kind of energizing me. So I'm hoping that we'll have an exciting next 2 hours.
Absolutely. And I'm looking forward to that. And this Life Class family typically brings beautiful, powerful, uplifting energy. So we're expecting nothing less this evening. So as usual, I'm inviting our audience members to reach out, invite somebody to log on. But before we get into the meat of the matter today, I would love to just pull up my slides one more time, just to help us to focus our attention on this evening's conversation and of course our housekeeping matters. All right. So here we go. Our topic for this evening's class again is chronic illnesses and pandemics, specifically focusing on staying healthy during COVID-19, because COVID-19 is not the only threat to our well-being at this time. And as I mentioned, this evening we have with us Dr. Patrice Francis-Emmanuel. She's an endocrinologist and an internist. And we are expected, hopefully, to be joined by Dr. Jeremy Thomas, who is a urologist, all right? And importantly, for those of you who are brand new to the space, we're going to be reminding us of some of our housekeeping guidelines. Firstly, we have our chat box where you can drop all your emojis, all your thoughts as we're going through the conversation this evening. We also have the raise hand feature for those of you who may want to come on stage and be brave and ask Dr. Emmanuel a question. And also we have the Q&A box, which is where we'll ask you to go and specifically put your questions, okay? And only the panelists, myself and Dr. Emmanuel, can see the questions and who asked them. And if you prefer, we will not share your name. So you can be free to ask whatever questions you might be maybe a little bit nervous to ask out loud in the chat box, in the Q&A box as well. An important feature of our conversation this evening, I want to remind us that whatever we're sharing this evening is meant for general information purposes. And so this is not intended to be medical advice for you specifically. In order to better manage your chronic illnesses or those of your loved ones, we invite you to always make contact, have discussions with your primary care physician, because health is a very personal thing. And so we need the information to be geared towards your specific issue, your health, your age, your stage of life, all of that, all right? So we're talking generally this evening, but we're asking you before you make any decisions, don't rely on Life Class information to do this. We're sharing it for information. Consult your doctor, right, who knows you and your history before making any medical decisions this evening. All right. So Dr. Emmanuel, here we are talking about health and wellness. And I want to say not so much COVID for this evening's episode, but of course, whatever questions the audience has, we'll be very, very keen to answer as many of them as we can. And of course, bearing in mind Dr. Emmanuel's areas of expertise, okay? We're going to stay in our lanes this evening. All right, so let me give some big ups. I see Shane. Hi there, Shane. I see Joseph. I see so many people just saying good evening. and welcome. I see Kelia saying, welcome, Dr. Patrice. I think Kelia might know you personally.
Thank you, Kelia.
Yes. All right. So, Doc, let me share a little bit about my personal business, right? So recently, one of my doctors said to me, Kamala, I think you should do a diabetes test. And Doc, I'm not going to lie, to Life Class is my special space. Dr. Emmanuel, I shed real tears, right?
Oh.
Yeah, because just the thought.
Yes.
Managing.
Of the unknown and wondering what is going to happen, what the results of those tests will be, which is not uncommon, not an uncommon response at all by patients.
And especially for me, given my age, I was like, I don't want to tackle this now, you know? And then as I shared on a couple of seminars and a couple of live classes, I have also been through a major illness, breast cancer to be specific. So the thought of having something else to deal with, I was like, God, please. Yes. So in your experience, Doc, you said it's not an uncommon response. So talk to us a little bit about the range of responses that you have seen from some of the persons you've served.
So I'm glad you mentioned diabetes, because that's the area in which I work for a large percentage of my work week. And we do know that the prevalence of diabetes in Jamaica is quite high. Up to 10% of individuals who are more than 17 years old, up to 75 years old, have diabetes. And a big chunk of that actually will be walking around without knowing that they have the diagnosis. So that is why it's so important to ensure that individuals are aware of what their risk level is, and that screening is put into place very early. So what you want to do is be able to identify individuals in this asymptomatic stage, in this early stage, so that you can help to mitigate the complications, which can be quite vast. So we typically, when we see patients, we try to assess their risk level. Age is one such, or weight or body mass index, as the weight compared to what your height is. The family history is very important as well, because we do know that type 2 diabetes is something that tends to run in families, as we would say. And so it's very important for individuals to be able to recognize their own risk by looking at the family members around them and seeing what is happening with them. But in addition, for their physicians to be able to identify those who they think are at risk and who would need to be screened so that we can identify issues early.
Yeah, I see Laverne in the chat saying my granddad was diagnosed at age 88.
So it's not uncommon for us to find, so diabetes is a condition, the type 2 diabetes, which is the most common type. It's present in more than 80% of persons. And with that type, it develops as a result of insulin resistance, meaning insulin is a hormone that's made in the pancreas, which is one of the endocrine organs close to the stomach. And it responds to glucose levels. So when we eat food, insulin would be increased in terms of how much the pancreas puts out to try to keep the sugar levels within normal range. And with type 2 diabetes, what we find is that insulin doesn't work as well. So even though the pancreas is producing it, and very often in very high levels, it just does not get, it doesn't have the effect that it should be as efficiently as individuals in whom there is no diabetes. And this is compared to individuals who have type 1 diabetes, where the pancreas is just not working, it's not making enough insulin. But with either of the two, the result is that the glucose levels will go up. It's not uncommon for individuals when they get to a certain age to start to have some amount of insulin resistance. So the development of type 2 diabetes is not at all uncommon as we age, which is why we say once you get to the age of 40, some would say 45 years old, especially if you have a family history or if your body mass index is above a certain amount, meaning your weight for your height, if you exercise minimally active lifestyle, so you're not physically active, and if you have other conditions like hypertension or take some medications, like steroids, for instance, which we know can affect the way insulin works, then screening would be very important.
So, Doc, I love how you're giving us some educational facts, because Life Class family, you know that we're in the JN space.
Yes,
and
of
we
course.
have giveaways, right? So we are promoting good information, and we also have, of course, some sweet treats for you all.
Okay,
so
not too sweet.
Not too sweet, right?
Okay.
And I think in terms of the experience, not the taste.
I understand. Just
so
staying
at
on your
some
word
point
there.
in today's class, yes, we're going to be offering 2 audience members the chance to win for yourselves an Amazon gift card from our beautiful host, the JN Group. And so listen carefully, because chances are, Doc, one of the questions or both of them are going to be based on the information that you're so beautifully sharing with us.
Okay, lovely.
Right? Let me pull up some comments, because I see our audience is engaging and sharing so much as they usually do. So Tiana says, both sides have diabetes, and I never took my diet serious. In my teens, I was diagnosed as borderline diabetic. And then she goes on to say, my dad has been diabetic since his teens, and it left him to become blind in his late 40s due to not controlling his diet. We had many death scares with him. Wow. So sorry to hear about this. And Laverne went on to say, I can understand being scared when you hear the word diabetes. When I was diagnosed, I thought I was about to lose all my limbs, because that is what I saw around me.
Right.
And Kiana now says she's on top of it. I monitor my sugar level at least 3 times per day, started watching my diet and exercising often. And her dad's mom died due to a diabetic coma. Awesome. Desiree is affirming our good doc so early. Desiree says, great job, Dr. Francis-Emmanuel. Very clear and helpful information. I fully concur. And we have a question which I'll pull up soon for you, Doc. But to frame the conversation, we started off talking about only one of several types of chronic illnesses. Yes. So I want us to go a little bit zoomed out to just give our audience members an understanding of what we mean when we say chronic illnesses. Let's list as many of them as we can think of, Doc. And then we'll go into some of the symptoms and the ways in which they're managed. And I'll definitely pick up the question here from Carol. And Life Class behind the scenes team, please hold this question for me and share it back with me in a few minutes. I don't forget. So, all right, Doc, what are chronic illnesses? Let's start there.
Right, so chronic illnesses, we started off with diabetes, but there's a wide range of other conditions which would fall into this category. So these are conditions in which individuals need to interface with their healthcare system repeatedly over many years, many months to years usually, and in whom long-term medication might be required. So in some of these conditions, it is not necessarily pharmacotherapy, meaning tablets or injections, but that long-term chronic care interfacing with your healthcare provider. Diabetes we mentioned already, but of course hypertension, which is very prevalent in Jamaica as well.
Doc, break it down for us. What is hypertension?
So hypertension, high blood pressure, or what people tend to call pressure. Many people, quite a significant percentage of Jamaican adults have high blood pressure or have pressure. And again, the thing with this condition is that it tends to not have any symptoms. So I know a lot of persons might say, I have pressure, but I don't need any medications because I don't have any headache. But typically, high blood pressure is asymptomatic. It doesn't really cause you to feel any differently than you would feel if your blood pressure is normal, until it gets to a point where it can cause catastrophic consequences. So your stroke, your heart conditions, etc. So that's hypertension and diabetes. We also have quite a wide range of what we call autoimmune conditions, and I'm happy Dr. Desiree Tollereed is here as well as our rheumatologist. Things like lupus, systemic lupus erythematosus, rheumatoid arthritis, those are autoimmune conditions, and by that we mean for some strange reason our body starts to make certain chemicals that start fighting against different organs in our body as though it did not belong there. And the management of these would be offering medications to try to suppress the immune system and to try to reduce the amount of inflammation that is meted out to these organs. Our lungs are not to be left out. things like asthma, things like chronic obstructive pulmonary disease, which we tend to find a lot in persons who smoke for prolonged periods or who may do certain jobs that result in inhalation of different chemicals over a number of years that may cause these issues to ensue. The kidneys, chronic kidney disease. This may be as a result of many of the other conditions we spoke about. So long-term uncontrolled diabetes, long-term uncontrolled blood pressure. Some of these autoimmune conditions may actually manifest as chronic kidney disease later on. And at the very end stage, these persons may actually rely on hemodialysis or other means of dialysis to survive, because the kidneys are very important in getting rid of toxic waste from the body. And if the function is impaired, then what we find is that these wastes build up in the bloodstream, and persons will now require significant assistance, whether it's by washing out the blood using machines or other modalities to try to help to clear these toxins. We haven't spoken about cancers yet either. This is a big C, the word which a lot of people do not like to mention. It can result from issues in very many organs. So breast cancer, we've spoken about that in many fora recently because of Breast Cancer Awareness Month, but this is not something that we should only be talking about during that month. It is something that individuals need to be empowered and educated about throughout the year, so that we're aware of the importance of screening, because you want to be able to pick up these things at an early stage so that interventions might result in better outcomes. The urologist isn't here as yet, but of course, prostate cancer, men's health, very topical now as well. So cancer of the prostate, which is quite prevalent in Jamaica. We can speak about things like chronic liver disease. So there are many conditions that may result in chronic liver insult. A part of that, which we speak of very often, is our lifestyle. So persons who consume a lot of alcohol on a long-term basis may in fact have chronic insults to the liver that over time may lead to a condition we call cirrhosis, where the liver becomes quite hardened, and left for long enough, then this might actually manifest as liver cancer later on. Wow. So those are just some of the chronic conditions which I think would be more familiar with persons out there. But there are a lot of others as well that could also be mentioned.
Doc, I'm thinking of another one, and tell me if I'm accurate in naming it as a chronic illness. You haven't mentioned asthma just yet.
Asthma, I think I mentioned asthma, but yes, asthma and COPD, those lung issues. And we're talking about chronic, for the most part, non-communicable diseases, but you do have those chronic communicable or infectious conditions as well. Chronic, HIV infection. We back in many decades ago when that first came into play, it was thought to be a death sentence because the treatment options were so minimal. And I remember as a medical student on the pediatric ward, we used to see quite a number of very sick babies coming in who contracted HIV from their mothers while they were either in utero or during birth. Nowadays, these cases are few and far between because we've gone such a far way in preventing mother-to-child transmission locally. And even in those individuals who contract adult HIV in later years, the treatment, if they're compliant and they adhere to their regimes, is quite effective. And individuals are living for decades, healthy lifestyles. So it's no longer considered a death sentence.
Which is excellent. And Doc, I tell you, the comment section has been blazing up, right?
Has it?
Yes, I see. We did mention lupus. Someone asked about sinusitis.
Right. So sinusitis is so very common in Jamaica. many of us suffer from it. It can be so distressing. So you have sinusitis, which can be acute. So individuals would have these postnasal draining, associated facial pain, etc. Sometimes you can have swelling. But this is more of a short-term thing and treated with antibiotics in the acute stage and will tend to go away. The annoying type is a chronic sinusitis, which lasts for years and years and years, and sometimes may actually flare up at different times of the year. So during the months when you have a lot of pollen, the allergic rhinitis would come into play, and there may also be exacerbation of this chronic sinusitis as well. There are many treatment options available, both medication and non-medication based. But sometimes when it gets to the stage where it's very severe, surgical options may actually have to come into play as well. So thank you for that addition, for the individual who mentioned that additional chronic condition.
And even in just general conversation recently, Doc, I'm hearing a lot of conditions among people that I personally know or people that they know, which we never heard as much about maybe like 10 years ago. So I know several persons who are managing like MS, multiple sclerosis. Somebody recently told me that they have Graves' disease. Some of these things we don't even know, the symptoms of them because they're not in our frequent experience.
Right. So Graves' disease is actually one of the conditions that endocrinologists would see quite often. It's quite common actually, at least within specialist centers. So we do get a lot of referrals from all over the country of individuals who have, it causes hyperthyroidism. So just to break that down a little bit, there is a gland in the anterior part of the neck, the front of the neck. It's shaped like a butterfly, and it produces hormones that we call thyroid hormones, which are very important in maintaining normal metabolism. When there is an issue with overfunctioning of the gland, your body makes a lot of thyroid hormones, which causes the metabolism to be increased. And so the symptoms of this condition would include excessive weight gain, and this occurs even when your appetite is increased. So if you were ever to find that you're feeling hungry a lot, you're eating a lot, but at the same time you're losing weight, this is just not physiological. It doesn't make sense. If you're eating a lot, you should be gaining weight. So if you find that happening, then that's one of the first things the doctors would think of. Some other symptoms would include a sensation that your heart is pounding, so you're having palpitations. You might be having tremors, so you can't write properly. You're sitting down and you're just shaking. Persons find that they're intolerant of heat. So you're sitting in a room, everybody seems comfortable. You're in your 20s, you're not menopausal, and at the same time, you're hot and sweaty. And there's a list of other symptoms. So the body basically is in overdrive. And Graves' disease is actually another autoimmune condition. So for some reason, your body is making these antibodies or substances that are stimulating your thyroid gland to make excessive thyroid hormones. It's a benign condition. It's not cancerous. It is quite easily treated with medications that are readily available locally. And there are definitive means of management as well, where at some point in future, usually not at the time of diagnosis, one can, use surgical intervention where the gland is removed, or you can use radioactive iodine to burn the cells out to prevent this overactivity. That, however, is going to result in your gland not functioning, and so you'll still need to take some medications to replace the hormones that are not there. Multiple sclerosis is a neurologic condition, so it's a condition that affects the nervous system. Once we used to think that multiple sclerosis was not really prevalent in our climate because it was thought to be a temperate climate condition, but we're finding more and more persons being diagnosed with the condition locally. And so it's definitely something to bear in mind.
Absolutely. And Doc, I see KD and F dropped another condition, which I've never heard of, undifferentiated connective tissue disease.
Okay, so that's along Desiree's expertise. But yes, there are lots of connective tissue diseases, which our rheumatologists are quite expert and are well trained in managing. And usually when individuals are seen by these specialists, they start off by speaking with the patient. So they try to get information on the different symptoms that they may be experiencing. There's pointed examination that is done to try to identify anything on the skin, with the joints, and more internally that might be abnormal. And specific imaging tests would later be requested along with specific blood tests. And these rheumatologists would pool all this information together to make a decision where they think these individuals would fall along the spectrum of these autoimmune or connective tissue conditions. So somebody has been either speaking with individuals with rheumatologic conditions, reading widely, doing their homework.
Or personally experiencing it.
Or personally experiencing.
I'm going to come
back. Yes,
I'm
seeing fibromyalgia. So there's a wide range of chronic illnesses, which I think we could sit here and speak till tomorrow before we were able to cover all of them. The important thing is I think individuals need to understand their own bodies. So I think it's very important to keep in tune. It's very easy for us to go through our days running to work, rushing in traffic, coming home, making dinner, going to sleep, and just continuing on that treadmill. But I think it's very important that individuals take some time to have what we call me time, to just relax, take in what's happening with their own bodies. And if something doesn't feel right, doesn't seem right, then I think it's important for us to reach out to our healthcare providers, expressing what we're experiencing and finding out whether this is normal. Is there something going on that needs to be investigated? So I think that's one of the take-home points from this discussion today.
For sure. And if the audience realizes we're being very intentional to go slowly and necessarily through the information, because I feel like there may be some persons who may be sitting in live class today who maybe perhaps are having aha moments as we're talking about some of the conditions, maybe some of the symptoms, whether for them or for someone related to them. Because as you said, Doc, I was about to go right to that point, that a lot of these conditions sometimes can kind of lurk in terms of like minute symptoms, and then they build up and get gradually more intense. And sometimes we're not as sensitive in reacting and responding to changes in our bodies because we think, oh, just because I'm eating too much pepper, or it's just because, the time get hot or something like that. So awareness is a big piece of the conversation.
Very much so. And it's actually because some of these symptoms come on so gradually, it's almost as though we start accepting them as being the norm. And we don't recognize that this is really not normal and needs to be challenged. I think a lot of it sometimes it comes out of a fear factor as well. You're experiencing abnormalities in the way you feel. The symptoms are clearly there, but the hesitation is there because we don't want to have a diagnosis of whatever it is that we're fearful of. The good thing is that for most of these things, if they're detected early, then the long-term effects will be far less than if we were to sit around and wait for these complications to set in. So the earlier, the better.
Absolutely. Doc, what about Crohn's disease?
Okay, Crohn's disease is another inflammatory type condition which affects we typically say from mouth to anus for Crohn's disease. So it is the cousin disease of something we call ulcerative colitis. These are inflammatory conditions which affect the gastrointestinal tract. It may present with ulceration, so ulcers forming anywhere along the gastrointestinal tract, meaning mouth, going all the way down into the intestines, all the way down to the rectum, the anus. people typically present with different symptoms. So there might be the weight loss, there might be changes in bowel habits. Persons may notice there's mucus coming out in the stool. They might be having blood coming out in the stool. And usually blood actually jolts people. When people see blood in the stool, that's usually one thing that gets them going to the doctor. But there are so many other symptoms associated with these autoimmune conditions, which might not be as frank as the blood, but need to be recognized because you know what your body is, and seeking care usually with your primary care physicians first, and then they would decide whether the need exists to refer you to somebody who might be more of an expert in that area.
Mm-hmm. Thank you so much for going through. So we've listed several, maybe more than we initially discussed, Doc. But
and the audience have listed quite probably the same number that I have.
Absolutely. Well. So please keep them in mind because a question is coming up in a few minutes. So let me just pull up some comments from our beautiful Life Class family. Sure. Carol's question is, what is the normal range? So going back to diabetes, right? What is the normal range for A1C and glucose fasting?
All right. So to make a diagnosis of diabetes, we have several ways of doing it. So the individual who comes into you with symptoms, and by symptoms, I mean symptoms of high sugar. So you're drinking a lot of water, you're passing a lot of urine, you might have recurrent candida, meaning thrush in the vaginal area for women. Sometimes the men can have that as well, blurred vision. So these are the classic symptoms of high sugar. So the patient comes in, they tell you they have these symptoms, you send them to the lab, they do a glucose, not a finger stick, no, we don't use that for diagnosis. We send you to the lab, you go and the phlebotomist draws the blood. If it's more than 11.1 millimoles per liter in our units, if you're using the units that they use in the US, you'd multiply that by 18, then that would be sufficient to make a diagnosis of diabetes. If it is that you come and you're getting a usual screening test, you don't have any symptoms, we send you to the lab again, you have not had anything to eat from 10 the night before, you go the morning, you have the blood drawn, you're fasted. If it's more than or equal to 7 millimoles per liter, again, that would be in the diabetes range. But we like to do what we call an oral glucose tolerance test. So we'll ask you to go to the lab, you have your fasting done, and then the person in the lab would mix some sugary water for you. It contains a fixed amount of glucose, usually mixed in about 200 mils of water, and you consume that within 5 minutes. You have the sugar checked in 2 hours. And if that again is more than 11.1, then again, you would have met the diagnostic criteria for diagnosis. Mm-hmm. So those are the ranges that we would use to say, yes, diabetes is present.
Thank you for that question, Carol, and thank you for that, Doc. A couple other comments. Veronica is sharing with us that her daughter was diagnosed with type 1 from age 12. I am traumatized since, but it's under control. She's now 25 and doing well. And we have been eating like her since. And I think it doesn't hurt, right?
Very good. That's excellent.
So good work on that, Veronica and family. Thank you for your kind comment, Elaine Grant Bryan. I'm seeing it. Another comment from Tiana says that some of her symptoms, she wasn't able to control her urine and it was embarrassing. I couldn't even hide what was happening from my children, etc. So she's just sharing her experience there as well.
Yes.
We have so many assistants in the chat dropping down some of what you are saying. Thank you for all of that. Denise says, both my parents died of diabetes and she's 47 and also diabetic and hypertensive. And coming into the lifestyle piece again, Doc, she says she's trying her best to eat right and exercise. And we're going to talk about what that really means, right? Mm-hmm. She's actually exercising now while listening. Very good.
Lovely multitasking.
Absolutely. And then now, let's see what else we have. I have always wondered how expensive PEP and ARVs are. So that's antiretrovirals. And tell us what PEP is, please, Doc, so I don't tell the people wrong things on here.
So I'm not sure if they're talking about post-exposure prophylaxis, but you also have what we call PrEP or pre-exposure prophylaxis. And by that, what it's meant is that pretty much you're trying to prevent yourself from contracting HIV if you were to have unprotected sexual intercourse with somebody who is positive. Also, we find that this is something that is used in the healthcare sector. So say, for instance, you're a young medical student, you've gone on the ward, you've taken blood from a person who's HIV positive, and accidentally you've sustained a needle stick injury. Patient is known to be positive. What we would do is that individual who has been stuck on antiretroviral drugs for a set amount of time to reduce the risk of transmission of HIV from that patient to that individual. So it can be done as well in persons who have had sexual intercourse with individuals who have been known to be positive, whether this was consensual or not, because we know, unfortunately, that there are situations in which this might be not consensual, and these victims are placed at risk of some of these sexually transmitted illnesses. The pre-exposure prophylaxis would be the administration of antiretroviral drugs as well before sexual intercourse in individuals who will be exposed pretty much to that virus from sexual intercourse, unprotected sexual intercourse. I can't quote to the costs. However, I am aware of, well, I'm not working in the infectious diseases area, and please correct me if there's anyone out there who's listening who knows more than I'm about to say now. But back in the day, we did have significant funding to the point where individuals who are HIV positive do not have to pay for antiretroviral drugs. I doubt this has changed, but I stand to be corrected. So as far as I know, it's free of cost, at least to the patient. And
the final condition I want to raise up for your reflection, Doc, is somebody asked about sickle cell anemia. Would that make the list of chronic illnesses as
Absolutely. How could I forget about sickle cell anemia? The prevalence, it's quite common in Jamaica. And we have different types of sickle cell anemia. We have also what we call the sickle cell trait. So there are those individuals in whom there is not the frank disease, it's not present, but they can pass it on to their children. In those individuals, we consider them to carry the trait. It results in, as its name suggests, a chronic anemia, so the blood count tends to be lower. So their normal blood count, quote unquote, would be lower than the normal range. So each person with sickle cell anemia would be aware of what is normal for them. They usually carry around a card with them. It says, my hemoglobin steady state is X. So that when they interface with the healthcare sector and the individual, the doctor who's seeing them, is well aware that when this hemoglobin comes back and it's 7, this is normal for this individual, and I don't have to be transfusing any blood. It's associated with a number of complications, and there are different things that can trigger these complications, or crises as we tend to call them. Being exposed to extreme cold. So these persons need to make sure they're warm. Especially when it gets to this time of the year, when it gets a little bit chilly, what we in Jamaica call chilly, which is warm for other places. Extremes of height, so hiking to the Blue Mountain, the oxygen tension is going to be a little bit lower. That can trigger a crisis. Any acute infection, so you have a pneumonia, you have a urinary tract infection, that as well can trigger a crisis. Dehydration. So these individuals are, they're well aware from years of education that making sure they stay hydrated is important to help to mitigate any complications.
So Doc, you've gotten some support in the chat regarding your disclaimer regarding the treatment for the prophylaxis.
Lovely.
Thank you, Margaret. She says, has it changed? Plus, there is the AIDS Foundation of Jamaica that makes access easier, but no charge at public sector institutions.
Wonderful. I'm happy to see that this is still the case, because that's so important.
Absolutely. So we've done a lot of reflecting and baselining so far, Doc. I'm calling it education tonight, health education on the multiple types of chronic illnesses And now I want us to talk a little bit about the relationships with patients and doctors, because apart from fear, apart from ignorance, there can also be that piece of maybe feeling embarrassed to ask certain questions of our doctors at times. Sometimes, I'm going to be very honest, some doctors' bedside manner is not the best. And I think one of the things that stands out for me, having gone through several doctor's visits, right, for various things, is just how important it is to have a doctor who is willing to explain things to us in a way that is easily understandable. Let me give you a quick anecdote about why I know it's important. My mom used to work at a particular hospital before she retired recently. And she sounds like me. She has a similar energy. So when people call, she's the first voice that they would hear.
Okay.
And so people tell her their problems, like all their complaints, even while she's trying to connect them to whatever department they want. So doc, there was one person who called, and they were telling her that they wanted to be connected to the maternity ward, and they were slightly panicked. She said she just felt led to ask them, is there something wrong? Because you sound a little bit distressed. And the person said that they were recently diagnosed with, they said, AIDS, right? And they wanted to get some other information because like everything is falling apart. My mom reached out to the maternity ward eventually. And before connecting them, she told them of the query that this particular caller had. And eventually the matron said there was no recent diagnosis in the timeline that this person is talking about. Long and short of the story, doc, is that the woman had given birth recently, and there was some issue in discussing her blood type. And there was something said about A+, right?
Oh no.
And in the patient's mind, they walked away clearly believing 199% that A+ must mean not HIV positive, AIDS positive. And as a result of this misunderstanding, when she went home and told her family about this issue, doc, all hell broke loose in the family, because the family fully went and attacked her baby father.
Oh dear.
And then say he's the one who must have given her AIDS. And when her mother heard that her daughter is AIDS positive, her mother collapsed.
Oh dear.
And so I walked away from
miscommunication
at the highest possible level. So even, apart from being a therapist and understanding the value of meeting everybody where they are and having relatable communication, it really highlights for me how important it is for doctors and patient care, experts to check for understanding whenever we give especially heavy pieces of information.
Yes,
and another one of my doctors said to me that he trains doctors, and he said to me, Kamala, if a doctor is not able to explain something, chances are they don't fully understand it themselves.
Very true as well.
Yes.
Totally agree.
Help us now in terms of some of the things that our persons listening who may navigate the healthcare system need to be mindful of in interacting with doctors, and tell us, for doctors who may be listening too, let's have a couple of reminders about how to engage in the best possible sense for good outcomes for our patients as well.
Right. That's such an unfortunate story. I'm happy it turned out to be an HIV negative patient, and that there was miscommunication. But that being said, you have so excellently summarized shortcomings and the deficits that occur in some settings. And I understand that it can be quite busy depending on where individuals are working. It's very heavy. I'm not going to say that it's easy at all in terms of for persons certainly working in the public health setting where the volumes are so high. But I think at the end of the day, making sure you spend the time with the patients to ensure that the correct information is transmitted will result in better outcomes for the patients at all times. And it was just today, I had a set of medical students in clinic, and this is something that we discussed, and I always try to hammer it home to the students who are coming in, just being exposed to the healthcare, to interfacing with patients, because they'll be doing the theory, yes, they're writing down, they're learning about anatomy and so forth, but when you're coming to interface with patients, you have to make sure you're at a particular level and that you're open enough to the patient so that they are willing to transmit the information they need to transmit to you. Because at the end of the day, we always say the history taking is the most important part. You're sitting and hearing from the patient. If they're not comfortable communicating with you, then you're not going to make the correct diagnosis, because that is where it all begins. So you have to first hear what this patient is experiencing in their own terms. You have to make sure that you make it easy for them to communicate with you. You're not standoffish, so that they're comfortable confiding in you. It's important as well for them to recognize that it's confidential. As long as there's nothing being said that's against the law, then whatever the patient says to you is between you and that patient. So you can't walk down the street and tell even a colleague, unless that colleague is involved in the care of that particular patient, what the patient confided in you. And I think that's something that needs to be brought across to the patient, because there are a lot of times when they're embarrassed, as you say. There are symptoms that they might be experiencing. Erectile dysfunction comes to mind, and I know our urologist might be joining us soon. But in diabetes, we see that very often. And we encourage our doctors to actually ask the patients, because many of them are not going to mention to you that they're having erectile issues, because it might appear to somebody who's listening, or so they think, that they're less of a man if that's an issue. But the presence of erectile dysfunction, and just to use an example, may actually tell you that there are other things going on. It's telling you that there might be issues with circulation, not just to that particular organ, but to the heart. And so one might need to look into the cardiovascular health to provide a holistic approach in terms of the patient's management. Mm-hmm. So I think allowing the patient to realize that you're somebody they can confide in is a huge part of providing healthcare. I also mentioned just today, that back in the day, maybe in my parents, my uncles and aunts, when they used to go to the doctor would say, okay, you have this, I'm writing a prescription for this, you go and buy that. So there's no discussion. You're not hearing from the patient. Have you explained what the side effects of these medications could possibly be? Have you explained what the prognosis for this condition is? Educating the patient, hearing from them, and having what we call a patient-centered approach, where the patient has a say in how they're managed, is very important, because you can prescribe all you want. If the patient said, look, I'm not taking this cholesterol medication because I hear it can cause liver disease, you can write prescriptions, it's not going to be taken until you sit the patient down and you say, look, cholesterol is high, it can lead to cardiovascular disease, heart problems, etc. This medication, although it has side effects, the risks outweigh the risks are much less than the potential benefits that it might offer. And just explaining it to the patient, allowing them to ask questions, answering the questions as best as you can. Because there are sometimes the patients will come to you with questions and you don't know the answers. Doctors don't know everything, and doctors need to recognize that so that you can move on.
I love it. And Doc, these are things that people can sniff sometimes. Like, is this person really zoned in on me as a person and not just on my docket number? And I'm fully there with you in seeing for myself that's in some context, there's the heavy patient, volumes, and it can be difficult to really connect, but at least some basic things, calling the patient by name, right?
Absolutely.
And
eye contact.
Oh my gosh, it's so simple, but it makes a huge difference as well.
It does.
Yes.
And you find the patients are much more comfortable as well when you provide that kind of environment.
Absolutely. I had an aunt who said to me, Kamala, I'm taking you to the doctor's appointment with me for my son who has epilepsy.
Okay.
Because I may not understand, like, you go school and know about bio, you're going to come because me not understand some of the language. And Doc, I promised you, I watched my aunt in that doctor's appointment, and the doc was speaking to her because she is, the patient's mother. And at the time, he was very much underage. And all she did was this, yes, doc, yes, doc, yes, doc. Because again, it's a cultural thing for some people that what the doctor say, you just say yes. And I was the one who had to say, okay, doc, can he take like painkillers on these medication? Like, things like those. Otherwise, she would have just said yes to everything and gone back home, right?
Yes. And I
Another
do
thing,
encourage patients. I'm sorry. Go ahead. I'm sorry, I cut you.
no, you go ahead.
No, I was saying I encourage patients. So a lot of times you might ask at the end of the discussion whether there are questions. And very often patients will tell you they don't have any questions. But I do encourage them in between visits. You're going to think of something next week or 2 months down the road or however long from now. Just write it down on a piece of paper so that when you come, because I don't know, sometimes patients come to the hospital setting, they're anxious, there are lots of other emotions in play, and they might not be thinking too straight at the time, but I do think if they jot any concerns or questions down in between visits, when they come prepared with those questions, then it makes for a more communicative experience and for their problems to be dealt with, for their fears to be allayed, and for their issues to be addressed appropriately.
Yeah. When you were talking about the fact that sometimes doctors can prescribe all they want, if there isn't that trust or checking for understanding and agreement, with the patients, they're not checking nothing. And I remember hearing a true case of a patient who had a prescription for some medication that was to be taken 3 times daily after meals. And the patient came back, maybe 6 weeks or whatever time after that initial prescription, and the condition was worse. So the doctor said, what's going on? You're not taking the drugs? And the patient said, no. And the doctor checked in as to why. And the patient said, doc, that I got tired of eating meal so much times for the day. Cornmeal is what they walked up understanding. Because where they come from, cornmeal is meal.
It's meal, right.
And what we understood was, me have to go eat only after me cornmeal.
Oh,
I must take the prescription.
Miscommunication again.
Absolutely. And so I have a doctor who makes a practice. If it is that somebody says, I have no questions, he says, I have a question for you.
Yes.
And quiz them really quickly.
To get the conversation going.
Absolutely.
That sounds like I might adopt that approach for persons who say they don't have any questions.
Absolutely. So that before we go into our first giveaway for this evening, we have 2 questions that I want to throw at you. One person says, can persons with an autoimmune disease currently with an active disease process be vaccinated against COVID-19, or should they wait until inflammation and other blood levels have returned to normal first?
I would say individuals who have autoimmune conditions, we typically have long-term follow-up arrangements with their rheumatologist or internal medicine physician. I would go further to say that all of these individuals, as they fall under the umbrella of those having chronic conditions, some may be on medications which suppress the immune system. They are at high risk of severe COVID if they should contract it. So while they're not at higher risk of contracting COVID-19, as far as we know, should they contract the condition, then the risk of being hospitalized, the risk of needing oxygen, going on a ventilator is higher. And so I would encourage anyone who has an autoimmune condition to consider going forward and getting vaccinated to protect themselves from the possibility of severe COVID. Of course, contacting your rheumatologist, having close-up one-on-one conversations with them, because they know the ins and outs of your condition, what medications you might be on and so forth, that they'll be able to advise further. But as a blanket statement, I would say for the most part, it should be fine to go ahead and be vaccinated.
All right, thank you for that, Doc. And I see how people are loving the suggestion about writing things down before going to the doctor. Because
not 100 things now, the doctors might chase you out, but
listen. And I saw Veronica. Veronica said, I am a nervous wreck when I'm to visit my doctor. So people come in sometimes with anxieties, fears. I don't want to be diagnosed with anything, or am I getting better? So it's important, again, to create that space. And the patient is also, I want to encourage us this evening to also speak up. right? Especially when you have a physician who's very much open to saying,
Yes.
do you have any concerns? You know, do you have fears? Are you understanding? Let's engage them so that we can encourage them to continue in that way and that we can have the best outcomes as well for our conditions. Another question here, can a person who suffers from Castrochondritis and allergic reactions be vaccinated?
So I'm not certain what Castrochondritis, certainly, yes. It's inflammation of the area between the sternum, which is the breastbone, and the ribs. Sometimes this can be brought on by acute viral infection. And so you might find if you were to press hard along the edge of the breast, of the chest bone, you might feel exquisite tenderness. And this can be chronic. There are persons who might have, short-lived costochondritis, which goes away relatively quickly after days to weeks. But in other individuals, this might be a chronic condition. And there's no reason why these individuals cannot go ahead and be vaccinated. There's a second part to the question, and costochondritis and something else.
Allergic reactions, but of course we're not sure.
Allergic reactions. Mm-hmm. So it is important for you to be able to understand exactly what allergies you have. Has this been a life-threatening allergic reaction, for instance? So have you had maybe penicillin before and had a condition where your airways got swollen, you couldn't breathe, you had to rush to the hospital, you had to be intubated to be assisted in breathing, versus somebody who's taken a medication which caused a rash, which went away after a few days. So there's allergic reaction and there's allergic or anaphylactic type life-threatening conditions. Mm-hmm. And we know that individuals who have had previous anaphylactic type reactions to medications may be at risk of reacting negatively to the vaccine. So if this is the case, then I would say speak to your physician. Also indicate this to the individuals who are in the vaccination center to say this has happened with me in the past, and the observation time, if you go ahead with the vaccine, would need to be a little longer than persons who have never had any episodes of severe allergic reactions in the past.
Mm-hmm. And that would be something that perhaps the patient would have to say to the nurses or whoever is managing the observation space that I need to be observed for longer. So again, learn
certainly.
To speak up. Absolutely.
Yes, absolutely.
So Doc, we're going to have a giveaway. And then we're going to continue into segment, let's call it segment 3 or second half of our convo this evening, where we're going to talk more about managing chronic conditions during the pandemic and also related to the vaccine and the virus, right?
Okay, no problem.
So my first giveaway question, everybody ready to type fast? And it's a very simple one. If you were listening, you should be the winner tonight, right? Name one, just one type of autoimmune disease. That's it. Oh, Jesus. No, life class family, only too serious. This is serious. So let me see now. Terrain, you see Terrain listed out everything, just waiting, right? Hoping that she would get at least one of Terrain. And Terrain don't have that particular one I'm looking for either. So I'm going to ask, so Doc, tell us a couple, remind us of a couple of them so that our life class behind the scenes team can help us to identify whoever said it first.
Yes, lupus or SLE or systemic lupus erythematosus, rheumatoid arthritis, Graves' disease, ulcerative colitis, Crohn's disease. Those are all autoimmune.
All right, so Kevin and Whitney behind the scenes, I'm going to leave this into your very capable hands to scroll through and check against what Doc just said and name the winner, and we will announce it shortly. So congratulations in advance to the person who will win, and we soon pull up your name and tell you. But me tell you, life class, not joke, everybody want to win the Amazon gift card. But remember, we have another one coming up in about 40 minutes or so. So please don't go anywhere and keep listening to what Doc is saying and what we're discussing as well. So Doc, we are living in COVIDous times, right? Perilous times in many ways. And I know there are several parts of this conversation about managing chronic illnesses and staying healthy, especially during a pandemic. One piece of it, of course, is making the decision about whether or not to take the vaccine, right? And also vulnerabilities based on whatever illnesses we may have. So let's start there. Can you tell us some of the conditions that may make persons more susceptible to contracting COVID-19 to start?
So since the onset of the pandemic, we've had so many different studies going on globally. These are various types of studies, they're different designs and so forth, just to try and get a better understanding of what's going on. And as far as I've seen on review of the literature, these chronic conditions don't really increase your risk of contracting the COVID-19 virus or infection. However, individuals who have chronic illnesses, especially if they are uncontrolled, tend to do worse. So these are persons with or long-standing diabetes whose glucose readings have been chronically elevated, they're high, they're not controlled. Persons with hypertension or high blood pressure who have persistently elevated readings, persons who are overweight or obese, so the higher the weight, the worse the outcome. By negative outcomes, what I mean is that these individuals contract COVID and they require hospitalization. Now, more than about 80% of individuals who contract COVID-19 remain either pre-symptomatic or asymptomatic, meaning they don't know they have it, they have no symptoms at all, or they have such mild symptoms, little aches and pains here, little runny nose, fever, intermittently, but not, protracted or too high, and can stay at home. But the other 20% will require hospital admission. And we find a lot of the persons who come to hospital are those who have chronic illnesses, and a large majority of those persons are those in whom chronic illnesses were uncontrolled. About 15% of individuals who contract COVID will actually have severe COVID, meaning they require oxygen, and another 5% will become critical to the point where they might need high dependency unit or ICU admission, or they may have significant end organ damage. So their kidneys malfunction, their lungs shut down, they may have injury to the liver. Of course, we know it's also, this is very topical, COVID-19 infection increases the risk of having clots. So while persons are wary sometimes of being vaccinated because of the risk of associated clots, which could be anywhere in the body pretty much, the risk of having clots once you're infected with the COVID-19 is actually quite significantly higher than the clots risk associated with vaccination. So I would say any chronic illness, increased risk of severe outcomes, but certainly especially if they're not controlled.
Wow. So, as you mentioned, those that are uncontrolled, I'm just realizing now the importance of conversations like these to give people the relatable information so that we can start to decide to make better choices as much as possible. Absolutely. And let's talk about some of what these choices can look like. So I know many persons right now, Doc, in managing some of those chronic illnesses, there may be real fear about going to the hospitals very often. I had a quick checkup to the recent and I was like, I don't want to go to UE because I'm hearing things, right? So I know some people are like, doctor, can we push back, Yes, so let's talk about the importance of following up, but also telehealth as a potential option for some types of consultations or treatment situations. To talk to us about those, Doc.
So we've seen this component or this aspect of interfacing with patients skyrocket or expand tremendously in the last 2 years. And healthcare physicians have just found that they have to get on board if they're to ensure that their patients are adequately managed. So there's a lot of fear involved. We know that if you come to hospital, there's the potential that a lot of COVID is circulating because that's where COVID patients come. And so persons with chronic illnesses, we have found, have actually been staying away. It's changing a little bit now, but initially there was such fear that there would be individuals at home with chest pain, persons at home with unable to move one side of the body, face twisted. So we know there's a heart attack, we know there's a stroke going on, but they're trying the Cerasee tea or the peppermint tea to see if things can improve. And by the time they find it's to the point where they need to come in, it's far gone. I think that is changing a little bit as COVID numbers are coming down. Persons are being a little more confident. Some are now vaccinated, so they're seeking healthcare as they should. But a lot of healthcare provision is now taking place without patients coming in the brick and mortar setting where they have to sit down and they're a few feet away from the doctors. Telehealth has skyrocketed, and it's a viable option for, as you said, a number of these chronic conditions. There's a lot that can be done virtually. Prescriptions can be sent virtually. You sit with the patients, you speak to them about their symptoms. Blood investigations are requested virtually. It's sent back to you electronically, and you can contact the patient to say what you think the management options would be on a virtual setting. But these are usually persons who are pretty stable, who may not need to be physically seen. On the flip side, of course, we have to recognize that there are those patients, two of whom, in terms of examples I mentioned, who will need to physically come into hospital if their care is to be appropriately executed. You don't want to be seeing somebody across from you at their home on the laptop who is having crushing central chest pain. We know that individual needs to come in, they need to have emergency care instituted and investigations done appropriately to ensure that the long-term effects of heart failure don't ensue. So a balance needs to be struck in terms of which patients will be managed by telehealth, but I think it's certainly a viable option and the way moving forward for a lot of these more stable individuals who suffer from chronic conditions.
Mm-hmm. And Doc, when we say telehealth, is this something that we can ask our regular GP or experts or specialist doctors to say, Doc, can I Zoom in or can I Microsoft into the session?
So they have some formal options available where the systems are in place to facilitate patient privacy as well, because I'm not certain Zoom is the appropriate interface for patients divulging private information. So you have to think about patient safety and patient information guarding. But there are options. I don't want to say, I'm not advertising any particular telehealth company, but they're easy to find online, and you can ask your healthcare provider whether they're a part of a setup like this. Or you can seek care from an individual who's a part of a setup like this, if this is something that you think would be appropriate for your particular condition. And of course, when you're seeing the physician, they will tell you whether they think this is the best means of healthcare provision based on what your complaints are.
That's it. Okay. So on that note, Doc, let me just jump over here to congratulate officially our winner of our first giveaway today, Carol Crooks. Big up yourself.
Lovely.
You are the winner of our first Amazon gift card. Congrats from myself, Doc, and the whole JN team. We are proud of you, Carol, for being so forward-thinking in winning this prize for this evening. And of course, all of you who typed out everything from minute 5 of live class to try to win that energy, because another giveaway is coming up soon. All right.
Absolutely.
So, Doc, we have a couple other questions in the chat box for us. Someone says, I have an addiction to juice and sweet things. With this in mind, I wanted to find out how much this will increase my chance of getting diabetes and how I can combat my addiction effectively. Doc?
That person has a lot of insight. Not very many people are going to tell you that they're addicted. So we're starting off on good footing there. And that individual is recognizing that there is an issue. Increased consumption of easily absorbable sugars like juice and cakes and desserts, ice cream, and so forth depending on the quantity. So I'm not saying you're not to have that at all, because I do indulge from time to time. But if this is on a regular basis, the risk is going to be there of increase in weight. And once you have an increase in weight, then insulin resistance is one of the things that would set in, and that forms the basis of type 2 diabetes, which, as I said, is so prevalent in Jamaica. But there are so many other chronic conditions which might spin off of obesity. Your cancers, hypertension, osteoarthritis, which we didn't mention, because if your body mass index or your weight is higher, then there's a lot of pressure that's put on your bones and knees. So when you walk around, you might cause a lot of long-term injury over time, knee pain, and then this is going to prevent you from exercising later on, because it's like a vicious cycle. So I would say trying to manage that sometimes can be quite difficult, but set yourself a target. Don't do it cold turkey, so you're accustomed to consuming quite a lot every day. Just cut it down slowly. You might say, okay, you're going to have this amount today. Tomorrow you're going to cut it down by X amount until you pretty much phase it out. And again, you might not be able to phase it fully out, but trying to consume less over time is what I would recommend. Trying to substitute it as well with healthier stuff. So there might be healthier vegetables and fruits which you enjoy, ones that have lower amounts of glucose in terms of the content, or fructose. For those in the audience who have children doing GSAT and know that it's fructose because they're helping with schoolwork.
Yes.
But cutting down on the caloric intake over time. And what we typically say, if you want to lose weight, you need to look at the dietary changes. If you were to cut down your consumption of calories by 500 kilocalories every day, then the weight loss, which we'd expect, would be about 1 to 2 pounds every week. So if you shave it down by 500 every day consistently, then that could be potentially 4 to 8 pounds a month. And our target is always about 5%, 5 to 10% over 3 months. So this is something that's doable. It might sound daunting initially, but it really is just small changes over a long period of time that would affect this.
Excellent, Doc. And I see Greg helping us in our conversation, just nudging us that most healthcare facilities have their own telehealth apps. He's used a few different ones just to see their med information security status. So Greg not playing with nobody with his personal information. I love it too, right?
Exactly, it's important.
And because of Audrey's question about if this recording can be shared with the participants, I just want to remind us that thankfully we are live streaming on Facebook right now. And so after class, you'll still be able to access the recordings on the Jamaica National Group's Facebook page. You can literally go on and just press it and play it. And you can, of course, click share to send it to your email or to your WhatsApp or whatever it is to share this recording. All right. So, Doc, we're talking about now the management piece, right?
Yes.
Of the chronic illness situations. And I know for some people, there are some frequent things that Jamaica people do as it relates to managing some chronic illnesses that I want us to amplify so that we can gently nudge people to say, this is not good to do. One of them that comes to mind readily for me, just on a general management of any condition, short term most times, is doctor give you 10 days worth of antibiotic and you take 4. You feel better and you stop, right? That's one.
Yes.
Another one is I've heard several people say, Kamala, you don't have the antibiotic left from the last, whatever, beg you someday. That's number 2, right? So Doc, walk us through in your expert and deep experience. What are some of the things that we do in managing our chronic illnesses that should not ideally be done? So we can just amplify that for tonight's convo.
Yeah. So the antibiotic is certainly one of the most common ones. And the issue with that is that you might be feeling better after a day or 2, but there's a reason the doctor said to take it for 5 to 7 days. We don't want to develop antibiotic resistance. So you're exposing yourself to the antibiotics. It's not killing off the bugs, but the bugs are getting a little bit of it and adjusting in terms of their metabolism so that when next year they're exposed to it, it's not as effective, and that can cause problems. But very often in the chronic care setting, certainly for hypertension, we hear persons talking a lot about the use of alternative medicines. Alternative medicines are very important. I think they form a very important part of holistic approach in terms of managing. And for the most part, I wouldn't tell people not to take the garlic for their blood pressure, but I would tell them that even though garlic has been found to reduce blood pressure a little bit, it's just about 5 millimeters mercury, 3 to 5. It's a small reduction. So it has been shown to cause blood pressure to come down a little bit. But if you come to me and your blood pressure is 190 and you take the garlic, it's not going to come down much. So while it's important for individuals to feel comfortable with drinking the peppermint tea, and as long as it's nothing that I consider to be toxic or that would interact negatively with the medication, I do still encourage compliance based on the fact that we're not 100% sure of how effective or efficacious these agents are. And like I said, they might not be harmful. They might not be as beneficial as we would want to think that they are. And many times if you tell people stop drinking X or Y or Z, they're just never going to come and see you again, because they're like, this is what my grandma taught me, this is what my mother has done, it works. But I do think that you need to provide, again, that setup where the patient is willing to tell you. Because it could be something that might interact negatively with the medication you're prescribing, but you would never know until the patient tells you. So provide that environment where they can trust and be open and say, yes, I'm taking turmeric or I'm taking ginger for this, and then have the discussion, get ahead from there. But I think ginger, turmeric, garlic would be the most frequent ones I've been told about. I'm not seeing a lot of people on immunogizer anymore. That was something as well in the not so distant past. I'm not sure if it's still available in Jamaica, but we do like to consume a lot of herbal and natural things, which nothing is wrong with, as long as you understand the place where they should be, and that they might not really result in the expected gains or the desired gains in ensuring that the complications of these chronic illnesses are kept at bay.
And for those in the audience who are physicians or aspiring physicians or in the healthcare sector, I love that point you made about creating an environment where the patient will be open enough to say, Doc, yes, may I take some of this, may I take some leaf of life or some guinea hen or whatever, because it's important to know. And if they feel as though you're going to bash them for it, then they're going to be like, no, Doc, not taking in nothing.
They're never going to tell you. You have
water and rice, right? I don't eat nothing else.
And then you won't be in a position to help them because you're not armed with that information.
Absolutely. And I love your point, Doc, that I also believe in the power of nature to give us some healing benefits. I think another piece to be mindful of, not to bash it, but to be mindful of, is the amounts, right? The dosages, because sometimes the difference between a healing agent and a poison is just the amount that we take and how consistently we're taking some things as well. Right. So
I would like to do things in threes for some reason, 3 leaf for that and 3 leaf for that. But again, you don't know how long do you steep it for? Do you boil it? Do you leave it in the hot water overnight? So it is going to differ in terms of the concentration, the preparation time and how it's prepared. So those things are difficult to judge, and so it now becomes a challenge on how you really utilize these agents to ensure that the negative effects are minimized.
I see a comment here from Melissa. She says, I don't use sugar or sweet things since I was a teen because sweet things hurt my head, even mangoes, but I don't have diabetes. And doctors keep saying they know, or I guess they don't know why, even after many tests. Have you heard of anything like this before, Doc? This kind of response?
Well, I'm not sure about sugar, but dietary, certainly some citruses, citrus fruits, caffeine, sometimes chocolates. There are different triggers for migraine. So there are some individuals who have migrainous headaches. And typically how we describe it, so you said it hurts your head, but I'm not certain what the description is, but I'll go ahead and tell you what the migraine headache would feel like, and then you can determine whether this is what you're experiencing. So it tends to be throbbing. It feels something like it's beating in the head. Very many times it's one-sided. It might be associated with nausea. You feel like you want to vomit, or sometimes you actually have vomiting. And there are individuals in whom, when this headache is there, if they're exposed to very bright light, or if they hear loud noises, then it can bring the pain on. So some of these individuals may find that specific foods trigger the headaches. And citrus is certainly one. Some people, other foods like mango. I haven't ever heard of sugar per se, but I think this is something she might want to look into to see whether this type of headache is what we call migraine.
Very well said. Thank you for that, Doc. And I learned something as well. And another comment here, a question: is it correct that we could be avoiding the obviously sweet items and still develop type 2 diabetes? And to what extent do our usual carbs, such as rice and flour and breads, contribute to developing this condition? I love this question.
Yes, I do as well. So certainly you could be doing all the right things, and your genes. So the fact that you have a parent or a sibling or some other first degree relative who has diabetes would portend a higher risk of your developing it. So certainly you could be following all the rules, you're eating healthily, you're exercising, but just your genes, the genetic component, would outweigh those other things. It's not to say that you shouldn't be doing the right things, because in any case I'm doing it, I can still get diabetes. But you need to understand what your risk level is, and ensure that your lifestyle is such that you try to cancel or reduce the risk of progressing to type 2 diabetes, because it can be prevented. And I remember somebody mentioning borderline diabetes early out in the conversation. Yes. They had borderline. The good thing is that, so borderline would be when your blood tests, I described some blood tests that we used to do to assess for diabetes. Blood tests are not normal, but they're not to the point where you're diabetic, so they're somewhere in between. And the studies that we know so well about, which seek to try to prevent persons from moving from borderline to frank diabetes, have shown that intense lifestyle changes are even more effective than medication. So if you've ever been diagnosed with borderline diabetes, or what we call pre-diabetes, it's important to get up, get moving, increase your exercise intensity, eat healthily, and in those situations, it potentially can actually be reversed to the point where your levels are normal. The risk is still going to be there of moving forward and progressing to type 2 diabetes, but there is something that can be done to prevent this progression, and it's free. You don't have to go to the gym and go outside and jog.
Exactly. And Doc, one of the things I like to say to my clients, even as we're talking about well-being, right, even in stress reduction, is sometimes when we hear the term exercise, we can feel like, oh God, that's not me. I'm not that type of person. So I like to encourage people to move their bodies with joy, right? Yes. That could be like skipping. It could be dancing. It could be running after your toddler, just in a very intentional, this is our runaround time. But do something to get your heart rate pumping for, I would say, about 20 to 40 minutes, as much as possible, because when we are exercise, we tend to feel intimidated. I feel like we have to go buy dumbbells and gym clothes and new sneakers. Yes. We literally can't just move our bodies. Just focus on the joy that we get from it and find something that works for you.
Right. Many people are working from home now. Instead of sitting for the entire day, just hoist the laptop. Standing is expending a little more energy than sitting. Walking around, getting up every so often, making sure you remain physically active. Somebody also spoke about diet. I didn't get the chance to touch on that. So a part of lifestyle intervention. So we talk about exercise, and we would say at least 150 minutes a week of moderate to intensity exercise. So if you say half an hour, 5 days of the week, you would pretty much cover it. And you did mention, Kamala, 20 to 40 minutes, which would be about where we would want it to be. We talk about Mediterranean diets a lot. So diets which are high in nuts and grains, low in red meats, low in fat, low in carbohydrates. So we eat a lot of, if you were to see a juicy beef breakfast, and you see 6 pieces of heavy starch with stewed chicken and lots of gravy, that's typically how a lot of Jamaicans eat. And this is a type of food, when eaten consistently, that would cause the increase in weight over time. So you're not going to put it on overnight. But if this is something you do consistently, then the weight is going to increase. And once the weight is up there, insulin resistance creeps in, and the risk of diabetes is present. So I think the portions are certainly important. We're not saying you're not to eat rice and yam, but just limiting the amounts, the quantities. If you're overweight or obese, shaving it down by about 500 calories a day and doing this on a consistent basis. We drink a lot of carbonated beverages. There is a significant move to limit this in schools, which I think is an excellent thing. But the adults, there's no limitation in the workplace, so we can still go and buy our Pepsi and all of that. And the carbonated beverages, very likely to cause weight gain over time. So persons might say, I don't eat a lot, all I do is drink, but then what are you drinking? So it's just a matter of taking a step back, maybe writing down what you're eating throughout the day, taking a food diary, stepping back and looking at it. Is this what I think I should be consuming moving forward to ensure that my lifestyle is as healthy as it could be?
And I love this part of the conversation, Doc, because to me, it feels very empowered. Like I'm going to be in the driver's seat of my care and of my well-being, and of course, pull alongside trained persons to help me. But I am taking responsibility and ownership over it as well. And I like some of these things are free to do.
Yes,
right?
you don't have to pay.
You don't have to pay a $15,000 gym membership to
No,
go walk.
No one who likes to exercise in the gym anyway, when you have the nature outside, all the birds.
Exactly.
To look at.
Exactly. And so, Doc, I heard you mention about even a food diary, which I love. I love that for a takeaway for our audience members this evening, because sometimes these practical things can help us to make it more real. Yes. And help us to better access it. I remember when I was studying health psychology several years back, our lecturer shared an experience about a child who was having consistent, constipation. And doctors were puzzled, not sure what was happening, what's contributing at the root of it. And you know what happened? It was a small child, maybe about 3 or 4 years old. And the child was terrified of sitting on the toilet seat, because they had a fear of falling inside. Mm-hmm. And so because of that fear, which wasn't realized by the child's parents or caregivers, the child just hold it in.
Oh dear. And the longer you hold it in, the longer the constipation.
Absolutely. And a simple solution that the health coach and the health psychologist were able to come up with was to provide a stool that was brightly colored and fun. Mm-hmm. And they created a whole storyline about potty time and how much fun it can be. Simple, doable, affordable, and that helped the child to have regular health.
Resolved.
Absolutely.
Excellent.
So I want us in a few minutes to tap into some of those small things that we can do to help us manage sometimes even multiple chronic illnesses that many people have as well, But before we get there, as usual, we have brilliant questions, because them people your life class attract, right? And I'm happy about it. So Melissa says, before I get to Melissa, there was a question in the chat about evidence-based practice as it relates to chronic diseases. So some people are rightly curious about how doctors know these things, how they, how the science comes about, especially as it relates to the illnesses that we call chronic illnesses and how we manage them. So Doc, please educate us on that part of it as well.
Yes. So we've come a long way in terms of how we practice medicine currently compared to how we practice medicine maybe 100 years ago, 50 years ago. There are professors of mine who have mentioned that back in the day, we used to treat heart failure with X, but no, that is something that should never be done. So it has a lot to do with ensuring that we offer the best for our patients and providing an atmosphere where, irrespective of where you are in the world, if you're a physician, you're faced with a particular condition, this is what is acceptable to ensure that the risks to the patient are minimal and the benefits are significant. And we come back to what we call evidence-based medicine, where we seek information. Back in the day, some people used to have to go to the library and read books and journals. Nowadays, it's at your fingertips. You can just open Google, go to a reputable journal, and see what recent well-designed studies have come up with. And there's a lot out there in the internet. There's stuff on Google that you can find that came out of just somebody's opinion of a particular issue, but you're looking for what we call randomized clinical trials, meaning these trials have been done in a rigorous manner. Their methodology is such that it prevents what we call confounding. You want to do something that results in findings that tell you that these were not chance findings. You want to make sure that the population that was studied represents your population. So we live in Jamaica, where a lot of us are of African descent. You will find studies that are looking at diabetes in persons in China, persons in the US. But you want to make sure that the population that was studied represents the genetic pool of the patients that we treat here. So a lot of it has to do with finding the appropriate journals, making sure that you read the studies properly, see how they were designed, how it was executed, to see whether the findings you get from that particular study can be extrapolated to your population. It's not just a matter of going on Google and looking up Graves' disease and saying this is how it's treated. You want to see that the studies that came up with this particular treatment were done in such a rigorous manner and represented the population that you're treating to the point where you think you are accepting of the findings and you are willing to utilize it in your population. So that's the essence of what we would do.
So it sounds like a part, maybe just one part of it, Doc, is figuring out that this is not buck-ups. This is not just one-off or two-off.
Mm-hmm. Exactly, but it was a well-done study and you can trust the results.
Absolutely. All right. Thank you for that, Doc. Very well and clearly articulated. I hear Melissa saying that I am familiar with and knowledgeable about the different types of headaches. I do have migraines and tension and cluster headaches, but I also do have FMS and an unspecified autoimmune disease along with systemic psoriasis. Still, none of that explains why I get sick if I eat buns, bullas, sugary drinks. They all make me sick. She also, Melissa went on, I don't drink any of these sugary drinks. I have to keep a food diary again that we're talking about, Doc, because of my sensitivity to many foods. You wanted to respond, Doc? I'm going to have to turn off a device which came on miraculously. So proceed, Doc. I'm right here. I'm just going to attend to it in a quick second.
Yeah. So I'm not sure what was meant, Melissa, when you said you get sick. Is it that you have vomiting? Is it that it exacerbates the headache? I think you had mentioned eating sugar and worsening of the headache. So I think it's very important that you're in tune with your body and you are able to easily identify the particular foods that cause symptoms. And as such, you're now able to avoid those problems. Mm-hmm. What came to mind out of my endocrinology background is that sometimes, again, I wasn't sure what symptoms you have after you eat, But there are conditions in which when individuals consume a lot of sugar or particular foods, within 2-3 hours of consuming those foods, they might have symptoms of low blood sugar. And by those we mean you're trembling, you're sweating, you're having palpitations. Sometimes we find these happening after persons have had metabolic surgery, bariatric surgery. So they're obese, they've had surgical intervention, whether it's to make the stomach a little smaller or to disrupt the whole anatomy of the gastrointestinal tract to make sure there's less absorption to cause weight loss. And sometimes after these surgeries, if they consume lots of a high volume amount of food, hours after that, they may have the glucose going low. The blood sugar can actually go low. And there are other conditions which may cause it as well. So the question is it that your glucose is going low after you're eating? Is it something that we call postprandial hypoglycemia, meaning after eating the sugar drops? In which case you may have to have some specific blood tests to see whether that is in fact the case and how we might be able to manage the condition. What we suggest for cases like that is consumption of foods that are less sugary. So you've identified the sugary foods cause problems, trying to stay away from those, eating smaller quantities more frequently. But sometimes medications may actually be indicated. So I think this is something you might want to discuss with your healthcare provider.
Absolutely. Doc, remind me for a second, Dr. Gregory House, our fictional, one of our fictional favorite doctors that we what was his area of specialty? Was he an internist as well?
He specialized in everything. I don't think he had any particular area. He saw everybody and diagnosed everything. I think I may have watched it 2 or 3 times. I didn't have the appetite.
I find it so interesting because even hearing how you teased out the possibilities of this based on the symptoms a while ago, my mind went there. But apparently it won't be a flattering comparison for you, so I'll leave it there.
That's fine.
I'm seeing on my screen where Dr. Jeremy Thomas is with us. Doc, can you hear me?
Yes, I can hear you.
Awesome. We'd love to see you. Can we see you now or soon? Is that a possibility?
Sure. Let me just figure this out.
Thank you so much for coming on. You were long, we were excited to have you on since last week.
Sure, my sincere apologies. Totally unexpected, and I'm very, very sorry. So signing, better late than never. So I'm sure a great discussion has gone on so far. Don't know if there's much more for me to add, but I'll gladly listen in. So hi to everyone, Dr. Francis-Emmanuel, and of course,
hi, Dr. Thomas.
Yes, hi, nice meeting you.
Good to have you, Doc, and thank you for squeezing in the time despite the medical emergency we had to respond to earlier today.
Sure.
And definitely, we have 24 minutes, 22. Lots of good things are going to happen in the next 22 minutes. But firstly, introduce us, please, to what urology covers. In a nutshell, what do you specialize in as a urologist?
All right, so it's a subspecialty within medicine. Really speaks to the genitourinary system and more so the surgical aspect of the genitourinary system. So what that means is your kidneys, the tubes from the kidneys, the ureters, the bladder, the prostate, the pelvic floor and pelvic floor disorders, and also the male reproductive system in particular, is what we focus on. So disorders of urination, of course, disorders of reproduction, disorders of erectile function, and other pathologies that affect that system is where we focus. Of course, the body, you can't isolate any system, so there are overlaps, and every system is dependent on the other for full function. As you recognize, if you bucked your toe, your entire world can be upside down, and that's just a little toe, But that's what urology really is, and where we focus the more medical aspect. or probably our smarter friends, the nephrologists, also focus primarily on the kidneys, but we sometimes work hand in hand, depending on what's happening with the patients as a present. Yeah.
So then some of your patients would be men who are experiencing prostate cancer.
Sure.
Treatment for that as well. Okay.
Yes. Yes. A large proportion of our men, and especially in Jamaica, and it may be a tired story, but it is the commonest cancer amongst our men. It's the commonest cause of cancer-related deaths in Jamaica and across the Caribbean, actually. So we see a high proportion, unfortunately, of men who have advanced disease, in probably up to say 50% of the cases, which really shouldn't be because they present when they're symptomatic. But yes, a significant proportion of our men do present with prostate cancer, and unfortunately, at an advanced stage.
And I was saying Dr. Francis-Emmanuel has done an exceptional job so far of helping us to understand and identify some of the ways in which, there are barriers to seeking treatment and the importance of seeking treatment early, right? So Doc, what are some of the things you want the men to know? Because we love that we have active participants in the session who are men, and of course, men, right? So what are some of the things you want our men to be mindful of as it relates to their health, their genitourinary health, and specifically managing prostate conditions as well?
All right, no problem. So if it is regards to prostate conditions and or men, in general, men and their approach to healthcare has always been a bit behind, definitely, the women or women who are much smarter than us.
I'm sorry, Doc. Doc, you sure you want to say that?
I will say it because, when you talk to males, there's really sometimes no good reason. Sometimes it's the appearance of being macho, or it's fear, and they're afraid to admit it, and it's just plain ignorance, really. So waiting until too late to seek relevant care. The whole thing of a stitch in time saves 9. So, but what I would say in terms of healthcare for men, it is important to have yourself checked out, even in the absence, even when you're feeling on top of the world. Certainly for prostate cancer, we have a big program in regards to promoting screening for prostate cancer. And that's because it's asymptomatic, meaning there are no signs or symptoms in the early stages of the disease. And it's, I would say, for the most part, slow growing. Not so much in our nation. We see more aggressive disease. But the thing is that it's asymptomatic in its early stages. Its course can certainly be altered if it's picked up early when it's confined to the prostate. And, definitely your quality of life and length of life can be significantly affected. And it's not just for you alone. And I think I said it in another meeting that it's your wives, your partners, your children, your family and friends who love you, that they get to see you for longer and the quality of life is better. So I would just say that, the age that we recommend for screening for prostate cancer in Jamaica is at 40 years old. And, it involves a simple blood test and the examination, the very feared examination, but it's not as bad as it sounds, so just get yourself checked out. And then thereafter, we usually recommend on a yearly basis that you have yourself checked out. It's not just prostate cancer, even though the month for prostate cancer awareness has just gone on. Sometimes there's a lot of focus on that and not so much on the other conditions which affect males, and in particular within the genitourinary system. So the prostate becoming enlarged as you grow older certainly is another common condition, probably even more so common than prostate cancer. And in fact, sometimes when men run in scared and they're thinking that it's prostate cancer because the urinary symptoms have changed, they can't pass urine so well, maybe seeing a bit of blood in the urine, burning, amongst other features that have changed with their urine, it's really secondary to an enlarged prostate, which happens, it's a combination of environmental and genetic factors. Some are even uncertain about, but certainly after the age of 40 or as you get older, it becomes more common. And so there is also that, so, they should have their prostates checked. So not just cancers, but also benign conditions involving the prostate. In terms of I heard Dr. Francis-Emmanuel speaking a bit about it, and she's probably could go into way more detail than I can, in terms of, lifestyle diseases and how they affect. Certainly, as I was saying to you, in terms of reproductive health, it's endemic to Jamaica in terms of diabetes and hypertension, hypercholesterolemia, and dyslipidemia. All these factors, which involve a lot of lifestyle, bad choices in terms of diet and not exercising and so on, certainly have a significant effect on erectile dysfunction that we see in men. And a host of whole other things across all the pathologies that we see in our males in the genitourinary system, so there's that we should really pay attention to. And that, in fact, if we pay attention to just diet and lifestyle choices, exercise, and so on, we could prevent a lot of the diseases that we see. So there's also that to pay attention to. Again, I will tell you this, sorry, hopefully I'm not all over the place, but again, I think society is a bit unfair sometimes. We stress very much and we pressure women very much to always look in shape, to be petite, to look good. And men, I believe, tend to get away with, a big belly is a sign of, is your sign of health, wealth. And it really isn't, and the same stress that is placed on a lady that says no, and there's a whole aspect of fat shaming and so on and so on. I won't get into that, but the whole point is that it's not healthy. And behind that belly, which if it is acquired just because of poor lifestyle choices, it's a host of other complications and other issues, from renal stones. Obesity is associated with even renal cell carcinoma. I'll tell you about smoking and bladder cancers and cancers along the whole genitourinary system, and so on and so forth. So, you don't want to make it to the top in terms of being financially stable, and then you have to spend all of that on, trying to regain your health. So for men, I would say, certainly when you're approaching age 40, get that male executive test, talk to your general practitioner, talk to your urologist, or if you do have a specific problem, I'd say start off with your general practitioner, your family doctor. They can, refer you to the relevant specialists, and you take it from there. But aside from that, just the general information that's out there for everybody, exercise, diet, sleep, those are some of the things that I think are just essential. Yeah. Right.
And I love attention to focused on the piece about not only waiting until something a pop down, right? Exactly. But also just do maintenance. Health maintenance is also
right. As I say, today. Sorry, yeah, go ahead. No, go ahead. Sorry.
I was thinking a very topical piece of the conversation, and because we are towards the end of class, I want to make sure to get it in not just a bite-sized way, is growing concerns about any possible correlation or causation between COVID-19 and erectile dysfunction or sexual impotence in some ways, and also the vaccine as it relates to men's sexual health. Doc, what is really going on and what is not going on, right? Because I'm sure the men are like looking at us sideways like, So talk us through, Doc.
Sure. So I mean, unfortunately, in this uncharted territory that we all find ourselves in, a pandemic. I don't think anybody was alive 100 and whatever years it was ago for the Spanish flu, which would have been, anything, probably the closest thing to what we have now. We've had smaller, outbreaks of different diseases, but nothing of this magnitude. Unfortunately, there's a lot of misinformation, a lot of ignorance, and hence a lot of, unnecessary fear and conspiracy theories. And, there are those with agendas who seek to spread fear for whatever reason. And uncertainly, they know what will touch people. And so definitely with regards to erectile dysfunction and reproductive health, it has been one of the topical things. So I'd like to dispel it, whereas I'm not an expert in terms of COVID. I can tell you I've looked at my areas and I've certainly seen patients, and I can tell you this, that our COVID itself is associated with an overwhelming inflammatory response, especially to the respiratory and the cardiovascular system. And I can tell you this, erectile function is very, very much dependent on your cardiovascular health. And in fact, the average middle-aged male who may present with erectile dysfunction, in questioning them and in examining them and in working them up for the cause, we take an extensive look at their cardiovascular system, because multiple studies have shown that it actually can herald or predate a significant cardiovascular event, such as a stroke or a heart attack, because it usually speaks to, atherosclerosis, which is simply just plaques developing within arteries, but it is as a result of, chronically high levels of cholesterol, dyslipidemia, and so on. And so in terms of COVID causing, COVID, let me start with COVID. So because I kind of went off a bit, right? COVID is thought to cause a lot of endothelial dysfunction from its overwhelming inflammatory response. And certainly the blood vessels to the reproductive organs, which depend on blood flow for their proper function, can be affected. So, there are a few studies out there that actually suggest that COVID is actually associated with a 6 times more increased chance of having erectile dysfunction, right? Mm-hmm. So it actually increases your chances. And there are multiple studies now that are actually being conducted across different nations to see if it is actually true, because it would hold that if it affects, people talk about the long COVID symptoms, and that affects your respiratory system, your cardiovascular system, there are a lot of people with CCF and so on, then that by right really should extend to your reproductive system, those medium to small sized vessels. So to be honest, if you're really concerned about erectile dysfunction, you'd really strongly consider getting the vaccine, because there is no doubt in my mind that there is an association between COVID, especially severe COVID, and erectile dysfunction. Now, people may suggest that those who actually suffer from severe COVID are those patients who have multiple comorbidities, which would have already put them at risk for erectile dysfunction. So there's that, the person who is diabetic, who is hypertensive, who has other illnesses on board, who is going to get that severe attack, they probably would have gone on to, have significant erectile dysfunction. But whether or not that is the case, there is certainly an association between, I think, COVID and erectile dysfunction. So certainly to limit your chances of any sort of severe overwhelming inflammatory response, which will result in endothelial dysfunction, which is then those blood vessels that carry blood to the vital organs that will result in an erection. You want to avoid COVID or severe COVID if possible. Now, in terms of the vaccines and erectile dysfunction, I know there's an infamous story from I don't know if I can call her name, right? The Trinidadian rapper who says that a friend of her cousin got an injection, right? Got a vaccine and then had swollen testes. Now, to be honest with you, most urologists or people in medicine will actually smile and laugh, because there's obviously something else going on there. It's definitely not the vaccine that caused that, or any of the vaccines. There is no way that the vaccines can result again in what would be known as an epididymoarchitis, inflammation of the testes or anything like that. Sure, you can have allergic reactions to vaccines, as you could have allergic reactions to anything, but very, very unlikely, right? And it is likely that the source of that swelling was acquired somehow, somewhere else via, the usual suspected methods. And maybe the vaccine was just kind of used hopefully as a smoke screen to clear himself as being innocent. But we won't go down that route because it's not for me to say, right? But definitely there is no evidence out there. You can search extensively. There's no evidence out there relating vaccines to the COVID vaccines to any sort of erectile dysfunction.
Yeah. Thank you so much for that, Dr. Thomas. I want to definitely create space for anybody who has any additional questions for our expert urologist this evening. It was an amazing job of catching us up in this very informative conversation we've been having so far. So you can raise hand to come on microphone, or you can drop it in the Q&A box. And I'm sure Doc stands ready to answer any additional questions, because that one, Doc, was very much like on many people's lips, right?
Yes, yes. I've met men who say, they've not finished completing their families yet, so they're not taking the vaccine until. Again, that's another thing. It has not, and there have been studies done looking at men before and after getting the COVID vaccines and their sperm count or semen analysis, which looks at the sperm count, how it moves, the normal number, volume and everything else with regards to it. And there's been no noted change. There've been no noted changes, I should say, with getting the vaccine before and after.
Mm-hmm.
So I dare somebody to actually show me evidence of that, but there's nothing to suggest that. Yeah.
I'm eager for another question, but let me run on to a couple of other questions that maybe Doc can quickly answer at least one of them before we have time called on us this evening. Another question was, I was diagnosed with having an autoimmune disease. My platelet went down very low. I was placed on steroid for a short period and it went back to normal. I now have black spots on my legs and thighs, but can't get a specific diagnosis. The spots fade sometimes, but get bright at other times. A few of them feel like a lump. A doctor suggested it might be bleeding under my skin. Could it be another autoimmune condition is the question. So Dr. Francis-Emmanuel, I think that's right up your alley.
Oh my goodness, that's definitely up your alley.
Dr. Thomas is like, yes.
Right. So from what I understand, this individual has been diagnosed with an autoimmune cause of a low platelet, so something like autoimmune thrombocytopenia, meaning your body again is making these chemicals that are fighting the blood lines and causing the platelet counts, which are those segmental components of the blood system that assist with clotting. The fact that you're having blotches, I think, dark blotches on the skin.
Sometimes feel lumpy, she says.
Feel lumpy could suggest that there might be what we call a hematoma or a little bit of blood collecting under the skin. But it's difficult to say without actually seeing. So I think that the next step would probably be to see the hematologist again, or take pictures at least of the lesions that are present. If it is that when you go to see them, they're cleared up, so they can have a better idea of what these look like and decide what specific tests to be done. So the rest of the clotting function should probably be tested, but I'm sure the hematologist would have already done most of those. But I think it's important to be able to see what you're describing. And if they're disappearing, it would be good to actually take pictures so that they can advise you better when you seek care.
Well said, Doc. And the final question we have time for says, the issue of blood clots seems to be rising and a lot of persons are on blood thinning pills. Some persons feel like they may have to be on those pills for life. Is there any natural food items or any other natural ways to address this issue?
So thanks for that question. I'm not certain if you're speaking about clots related to COVID, clots related to the vaccine, etc. But clots in general, when they appear in the venous system, so if you have a clot in the leg, the potential is that it can migrate to the lungs and cause what we call a pulmonary embolus, meaning it's now located in the lungs and it can cause significant distress. So once this is suspected or confirmed by specific tests, it's important that blood thinners are in play to prevent any worsening of the symptoms, any cardiovascular complications, like the heart might be significantly affected. Once we have started treatment, we need to try to figure out, why has this person developed a clot? Is it something that's reversible, quote unquote, or is it something that's not reversible? And if it's a risk factor that's persistent, for instance, this individual has a cancer on board, which is not curable. So we know if we stop the blood thinner, the risk of having a recurrence of the clot or expansion of the clot is there, then these persons may have to continue it long term. If this is a clot that develops because you are pregnant, you've now already delivered the baby, you're up and about again, you're no longer immobile, then chances are we can stop it after a shorter period. But I think it's always going to be patient-based. And as far as I know, there's no specific diet that I would recommend to replace those anticoagulants.
Got it. Thank you, Doc. And Dr. Thomas, there's a question here. The person says, I usually thought that only men go to a urologist until when I found out that I had endometriosis in my bladder and was referred to a urologist. Something goes to Doc?
Absolutely. And in fact, not just endometriosis when it deposits. So that can actually mimic other conditions in urology. So they, can present with bleeding, hematuria, which is blood in the urine, but that's usually cyclical. But there are a host of conditions that women have that we actually treat. So yeah, that's actually another bit of misinformation, that we only treat men because for renal stones, stones anywhere within the genitourinary tract, masses, anything of that sort, they're distributed amongst both sexes. Pelvic floor disorders that result in urinary issues, again, both men and women actually present with that. So yes, a couple of our commoner conditions are, with regards to the prostate and as men get older, but certainly we do see quite a few women. So yes, endometriosis, that abnormal uterine tissue, which is deposited within the bladder, which we'll have to scrape, or depending on what it is and how extensive it is, whether medication or surgery may be required, is amongst the conditions that we treat. It's not so common, but it is very much so a condition that we see amongst other conditions that women have that we definitely do see.
So Doc, if someone were having an issue with their bladder, whether overactive bladder very loosely or something that they want to query, you mentioned that you work with the nephrologist sometimes. Which one of those experts perhaps would be a good place to start that exploration as well?
When you say start in terms of?
As in moving from GP to say that there is something that's happening here, into now going to a specialist to get some testing.
So the family doctor actually does a great job in terms of kind of sifting through and determining where the patient should go. For urinary symptoms, I think you'll tend to end up going to the urologist first. It is when there is noted to be, sort of significant renal impairment, or systemic illnesses that affect, where it results in like parenchymal disease, so the kidneys don't work so well anymore, or even if that is as a result of chronic structural abnormalities within the genitourinary system, that we actually combine our forces, for the health of the patient. But yeah, that's a kind of difficult question to answer. But I think that, yes, something like overactive bladder, you're definitely being sent to probably a urologist first, or any changes within your urinary system. Then you would be sent there, and we look at, between examination and looking at relevant investigations, we then determine what may be the cause. And then we may have a discussion with the nephrologist on board, and we figure it out from there.
Got it. Yeah. So now time has been called upon us. We are watching the clock. And before we go, we have the second giveaway for a lucky member, an attentive member of our live class this evening. So our final question for the giveaway is to the person who can first respond correctly to this question, right? Dr. Jeremy Thomas came on live class and said that the age at which men should start oh God. Carol, I'm not playing with you, So congratulations. So yes, Carol was like, already. Congratulations to Carol. Right. You have won, I think, another giveaway, because Carol won the first giveaway, right, Dr. Emmanuel? I think it was Carol.
I think so too.
Oh, well, congrats to Carol. Sharp.
And also to all the people who have correctly gotten it, even though you don't win a prize, big up yourself, you've been paying attention. And I want to just say here a tremendous thank you to all the presenters and all the panelists who were part of this special 3-part series tackling the virus and the vaccine. This evening's panelists were absolutely profound and so easy to listen to. The commendations are high for the session. Someone said, I'm impressed with JN, how much they're concerned about their clients' financial, but also their health, right? Their physical health. So big up JN. Thank you to the behind the scenes team that helps to make this a reality. Thank you for all you do. And to Dr. Patrice, Francis-Emmanuel, and Dr. Jeremy Thomas, who braved the medical emergency and found his way on live class and served us so expertly. Thank you a million times. And to the live class audience who come back week after week after week with the good energy, the amazing questions, right? And the beautiful feedback and affirmations. Thank you also. To all of you on this Wellness Wednesday, we're closing off our 3-part series, but JN don't done yet. because we're likely to come back with another season of Life Class. So please just keep taking care of your good selves, and especially on this Wellness Wednesday, be kind to you and be kind to those you love. Until next time, doctors and everybody, thank you again and be well. Take care. All right.
Thank you very much.
All right. Thank
Great
you.
to have you. Looking forward to talking again. Bye-bye.
All right, bye. Thanks. Bye.
Bye.